Hello, my name is Ari Javidan, and I'm the program coordinator for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC. Oh, sorry about that. Looks like my screen went down. One sec. There we go. Welcome to the latest presentation in the NCTRC webinar series, Pandemic Response Action Plan and the Opportunity to Use Its Lessons to Improve Healthcare. Today's webinar is hosted by the Telehealth Technology Assessment Resource Center, TTAC. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs, and they are presented on the third Thursday of every month. Just to provide some background on the consortium located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please note that closed captioning is available and is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinar recordings and slide decks on the NCTRC YouTube channel. And with that, I will pass it over to Patricia, who will be introducing our speaker for today.
Hello, everyone. I'd like to introduce to you Mark Vanderwerf. Mark's title says Telehealth and Telemedicine Advisory Consultant, but I highly recommend you read his bio, as we don't have time to cover the many key roles Mark has played as a telemedicine business and thought leader. What I will say is that Mark's ability to recognize and communicate the challenges and opportunities of telehealth technology has made him a great asset to the Telehealth Technology Assessment Center. So with that, I'd like to turn it over to Mark.
So good morning and good afternoon, everybody. As I've already been announced, so I'm Mark Vanderwerf. I've been in telemedicine for a long time, and I know a lot of people that will attend this. So let me say hello to all my friends out there, and thank you for coming. The purpose of this, or the topic of the day, is this Pandemic Response Action Plan. And let me get into a few more details around that. So we were asked in 2020 to construct the Pandemic Response Action Plan. And as part of that was really to look at the critical challenges that were facing providers during the pandemic. And initially, this Pandemic Action Plan was to prepare us for a future pandemic. Of course, COVID-19 hasn't left us yet. So many of the things that are within this plan are focused on not only future, but also on this. There were three major deliverables in this. So I'll get to it in a little more detail. But was to create an action plan that applies telemedicine e-health to address each of those critical challenges. And really step back and find out what could we really do to solve some of these problems, but not just throwing more people at it, but by throwing technology. The plan itself was completed in the beginning of last year, and it was published in the journal. And it's also on the TTAC website. The second step was to take a real in-depth look at the regulatory landscape. What are the regulatory policies in place? What are the reimbursement issues in place? And as part of that, make recommendations to policymakers as to what we could do going forward. As the slide says, it was published in the journal. And one of the things that came out of this is January of last year, so January of 2021, there was a lot of talk of ending the waivers or figuring out when the waivers should be ended. We joined with the ATA, American Telemedicine Association, the American Hospital Association, the Consumer Technology Association, and others to recommend that the waivers be continued for 2 to 3 years from last January. I'll dig into that a little bit more as we go. The part that we're in the middle of now is to look at basically the impact of using the elements of this plan in hospital networks in the United States, again, during the plan. We looked at 8 programs that were identified by the TRCs and TTAC. We interviewed them in depth to really understand, so what happened in the middle of this crisis, and how did you implement it, and what was the result? The final report will be is being written today. It'll be finished at the end of March. It will then be submitted for publication. And a big part of that is really conclusions and recommendations against all 3 of the sections of the pandemic response plan. The team, we tried to really not have any inserted bias as we wrote these programs. Bias is a hard thing, but to get as much away as we could, we really tried to go for a broad team. The TTAC and the TRCs were represented. There were nursing, physicians. We had 2 C-suite executives, one from Humana, one from HCA. We had, of course, technologists, 2 infection control physicians, one in a very rural area and one in more of a denser area on the East Coast, then public health, and of course some emergency response. That was the primary core of the team. For the interviewing of what happened, we had also the leaders of the 8 providers that implemented the tools into their operations. So the output of the project is 3. It's got 3 phases. It got a report for each one. The first is the Pandemic Response Action Plan itself. Again, that has been published. You can go get it right now from the journal, or you can go to the TTAC site within their toolkits. It's there. The regulatory reimbursement issues, again, that's been published. It's ready. You can go to it either through the journal or through TTAC. And then phase 3 is where we are today. And this one digs really in. It actually was, in some ways, a very interesting part of the report, because we had spent a year on the first 2, and then really another year digging into what actually happened. In addition, unlike a lot of the reporting that's been done in this area, we decided that we would submit all these reports to the rigor of peer review. This is a higher level, not only of review, but also to a great degree, a higher level of credibility. Our approach was structured brainstorming. Structured brainstorming is a technique we use basically to try and get as much out of your think tank, this group, as possible. And rather than try to focus on answers and then kind of go from there, it doesn't focus on answers at all. It focuses on the problem and it focuses on the questions. And to a great degree in this technique, it's assumed that the answers build themselves. If you really know the problem and you really know the real questions, it's a lot easier to get to the answer. So, what did we find? These were the critical challenges that we identified. There's 11 of them. There is some overlap in these. That overlap is intended. But some are really basic. And keeping protocols up to date, obviously. Keeping the hospital open, that's an operational question, it's a financial question, it's a staffing question, but how do you keep the functions going in a crisis? Especially in a crisis that impacts directly your revenue. And the rest of these are pretty self-explanatory. You have to protect, divert the potentially infected, you've got to answer critical staffing needs, which has gotten a lot of press, but is a serious issue. Trying to contain the infection within your hospital, providing access to care, even though a crisis is going on, even though clinics were closed, even though there was a moratorium on elective surgeries and procedures, et cetera. Patients still need you. Care at home, challenges related to that. And in many hospitals, that created an ability to rotate the patients in and out, out of the hospital to allow better capacity for the hospital itself, make beds more available, et cetera, et cetera, et cetera. Supporting remote work and staff, behavioral health is a critical area that was identified separately. Transportation was an interesting challenge, especially for rural areas, transporting people, transporting supplies, et cetera. And last but not least, in this crisis, public health. So if you open the front pages of the plan, you'll see that each one of those 11 areas has their own section. And in each section, the problems are described in a paragraph format. This presentation is going to have enough eye test in it already, so I didn't leave it in paragraph. I converted it for the purposes of this presentation. But again, the problems are discussed first. Then the solutions and the ideas are presented in bullet format. The reason we did this is because, well, again, we're focusing on the problem, and we also wanted it almost to look like a checklist. So rather than going to every single solution and going to in-depth description of what it is, this identifies what the solutions are, identifies what ideas are to address them, and puts them in a bullet format that you can cut through almost like a checklist. Now, I'm not going to go into all 11 because it would take a long time. So I'm going to give you samples of what we saw. And I've chosen at random section number 2 and section number 6. So keeping the hospital clinic open and access to urgent care. Actually, access to care, period. So number 2, keep the hospital, the clinic open. What are the problems? Well, a biggie is sharply reduced revenues. With the freezing of elective surgeries and the closing of clinics, et cetera, some of the most profitable or best margin services the hospital ended, or at least were suspended. And then at the same time that the revenues were going down, the costs were going up. And this kind of gives you an idea of some of the costs that we're talking about. I'm not going to read through that, but because you can. But also, these are not. These are pretty logical. And then another piece that we looked at is the continuity of care. The continuity of care interruptions for patients. Really a serious issue. Loss of staff due to infection, fear of infection, stress, family, et cetera, et cetera. Trying to keep your staff healthy and productive, both physically and mentally. And then we looked at the impact of quarantine, both on staff, if they've been exposed or infected, and on patients. So those are examples of bullets of the problem. These are samples of the solutions. Some are really straightforward. Keep infection risk to a minimum, and then we talk about how to do that. One of the ways is to divert the potentially infected before they arrive. Don't bring them into the hospital. Go ahead and conduct the appointments with telemedicine, bill for the encounters. Most people did this. There was still resistance to it. We are coming up much more strongly going, this is the way you should approach it. This is the part that works. Allowing people to work at home, which also may reduce some staff stresses, because those people in quarantine at home, if they are not ill, can continue some of their operational role. It's a major issue. Assuring connectivity to the home, especially in rural areas. This is a problem. You're all seeing it. And don't do this when the crisis arrives. Using this kind of technology should be part of the normal operation of a healthcare provider. And connectivity is a key part. And making sure that at least your employees all have connections is critical. And this should be examined. A survey should be created, and it should be done every year. Keep it up to date. When crisis hits, is not a time to do this. Close down and get rid of physical waiting rooms. Many people did this, some did not. Basically create virtual waiting rooms, etc. In the later parts of the report, we really began to realize just how much overhead is in waiting room space. 20-25% of of clinics are just are not delivery, they're waiting rooms. That's a terrible waste of time or waste of space. Keep infected people out whenever possible. You'll notice in here it says C number 3 below. All of the sections of the report cross-reference. So it says that twice in here. In section 3, which is directly on infection control, you'll be connected into more detail. Simple stuff like using a pad and a pole to reduce demand for PE and allow patients to have access, allow physicians to have access. This was a major savings. Let me give you some math. So let's say you have a nurse and they have 12 patients that they're rounding. And they round all those patients every hour. That's 12 sets of PPE per hour. 8 hours for the nurses that were lucky enough to be working only 8 hours. And that's 96 per day for that nurse. If you have 10 nurses, that's 960 sets of PPE. 3 shifts means that you use about almost 3,000 PPE just for nurse rounding. That doesn't include physician rounding, food service, visitors, et cetera, et cetera. It's a tremendous consumer of what was for many parts of the pandemic a rare resource. Now we're going to jump to another section. It's called provide access to urgent care. It's basically provide access to care. The problem, the demands of consumers, and we talk about consumers here as a broader term than just patients. Patients are consumers. Consumers is a bigger view. But the bottom line is consumers and patients, however you want to look at it, still needed the service. They still needed urgent questions answered. They still needed diagnosis. They still needed to be given guidance by the care provider. It didn't go away. Got to deal with that. We know that patients will resist coming in due to infection rates, so do providers. Both sides want to avoid exposure. At the same time, providers are critically impacted. A good provider wants to provide care to their patients, and there was a major interruption in this. Number 2, the revenues were cut. Number 3, again, infection exposure for them was a daily concern and remains a daily concern. And we identified significant impacts due to the isolation from care. Some of the things that are coming out in the literature is that a lot of chronic disease patient areas, and one that's really featured is CHF, there was an excess death rate increased death rate in CHF. It's mostly blamed on the continuity of care being interrupted. So those are real impacts. And another problem is it's really hard to set this up in the middle of a crisis. Some of the solutions for that section, go ahead and create direct-to-consumer services. Make it part of creating a digital front door. Not only is this address many of the problems that we just saw on the previous slide, but it changes the way you can deal with your patients in the future in a critical way. Obviously, you have to choose a video platform that you use, but make sure that when you choose the video platform, that you take into consideration usability by the patient consumer. Don't have a separate scheduling system for remote and in-person. Same scheduling system. Adapt your workflow accordingly. Whenever possible, you conduct the follow-up visits remotely. Make that the rule. The next one kind of repeats, but implementing direct-to-consumer urgent care as a course of business and for preparing for crisis situation. We're going to retouch on that a little bit, but let's not wait till the crisis. Let's put it as a normal process, which really helps the flexibility and sustainability of an operation when a crisis occurs. And to go for the direct-to-consumer, there's a complete direct-to-consumer telemedicine assessment toolkit on the TTAC site within their toolkits. So we continue to go through all of this. So every one of the 11 problems were constructed the same way. Heavy impact on, or heavy analysis on the problem, and then identifying the problem, identifying solutions. So the last piece of the project, the phase 3 of the project, was to look again at what happened within 8 different healthcare providers. All of them were hospitals, and most of them were small hospitals, a couple of medium-sized. And we have a complete section on what did we learn there, but we also kind of finish with conclusions and recommendations for the entire project. So I'm going to go into that last section, the conclusions and recommendations. I am not going to dive right now into the lessons learned in that section because it's an unpublished document. And I'm basically using this as bait to get you to read the document when it is published. But let's go into kind of some of the conclusions and recommendations. And these are aimed at the entire 3 phases of the projects. These are all preliminary. These haven't been published. They haven't been peer reviewed. So these are just samples. Conclusions were that based on the evaluation, the look at all 8 of these programs is when they applied the tools within the plan, they helped themselves address the critical challenges. It was a direct corollary. A big thing is implementing these tools during a crisis is difficult, very difficult. You're in a crisis, and now you want to do many of the things you have to do to set up virtual. The hospitals that we talked to, many of them had at least a fragment of digital tools, telemedicine implemented. If they didn't, it was desperately difficult to do everything you had to do and at the same time try to stand up virtual environment. Again, kind of with the people that had it in place had a significant advantage going into this. Another observation is that we're complaining about a lot of problems, but almost all the weaknesses that COVID-19 exacerbated during, and is still exacerbating as the pandemic proceeds, already existed prior to the epidemic. This is not new. None of these things are new. We just haven't addressed them properly. And the pandemic is not really addressing either. We have work to do after the pandemic. And these include all the things that we're talking about, staff shortages, old-fashioned workflows, yada, yada, yada. I'll let you read that one. Prior to the pandemic, most healthcare processes were still processes of the 1970s, and many of them still are. I know that, I think most of us know that already, but one of the things that the pandemic should have told us is that it's time for a change. And there is a real risk of rebounding back to the old workflows. And many of them are, and of course, most of them old workflows are still in place. What we're recommending, of course, is this is a unique opportunity. I mean, don't look at it just as a disaster. Look at it as a reflection of the healthcare system and the problems that it has today. Part of our recommendation to CMS, along with those other organizations, was, yes, you have to properly know the value and cost of telemedicine in order to set reimbursement rates. But look at this as a unique opportunity. Understand the true value and cost to allow you to put in much more appropriate reimbursement policy. And that's what they reacted to. So I'm going to dive into just, I'm bulletizing now to kind of give you an idea of the other conclusions that are in here. Conclusions, of course, that we're still using in-person visits when in-person visits really aren't necessary. Physical waiting rooms plus physical waiting rooms and physical check-in is what this really should say. These are really kind of an obsolete concept. Where else do you go in any other industry where you don't fill out your registration online before you go? It's about time we start using it. And one thing you see in very few businesses anymore is waiting rooms. Virtual queuing is a completely acceptable and completely developed area. focusing on registration online. I did some work some years ago with IBM, NCR, and a company called Vecna to look at how more accurate registration online was, or at a kiosk was, than registering at the front desk. The delta was amazing. The accuracy of letting a patient register online or register at a kiosk was almost 50% more accurate than the person going to the front desk. We're teasing everybody here about the clipboard. How many industries still have you fill out something on a clipboard? It needs to go away. Inefficient care workflows and the normal workflows is an issue. An assumption that the only staff you have is the ones that are inside your building. And yet with programs like tele-ICU, telestroke, et cetera, you have access to resources outside of your facility. That can go for almost every other expertise area. Incentives, patient preferences need to be, patient preferences basically haven't been completely engaged. That's a conclusion. A source of medical truth is critically needed. We saw so many different versions of truth during this whole program. Many of them accelerate, many of the splits accelerated by political issues. But the fact we don't have a single source of truth is a critical issue. Moving the home is critical. Technology is not a panacea. We get into more detail. Again, these are bullets just for the purpose of this presentation. Every one of these things has backup to it within the final plan. And these are recommendations. And these are samples again. Biggest thing is preserve the advancements achieved through COVID. Figure out a way to maintain the incentives to motivate and sustain behavior. We are recommending now that we know more about the pandemic, and along with many of the other associations that we worked for before, is that the waivers should be maintained for at least 2 years past COVID-19. That's what we're recommending. And I know there are 2 bills before Congress right now to do exactly that. So hopefully our recommendations will have some weight. Again, use the opportunity to learn from the pandemic, restructure incentives, et cetera. Step back and look at how the workflows are being used, but don't work at just how to continue the current workflow. Figure out how to use efficient technology and workflows to better use staff and their skills. Another recommendation is a more expansive relationship with patients. I'll get into a little more detail on the next slide. And here it is. A more expansive relationship basically will help us to not require in-person encounters. And some of the ways that you can increase that is, of course, integration of the various RPM, CCM, and care coordination into your normal course of business, and really move toward looking at the patient as more than just in the hospital, but what happens with them, around them after they leave. We've been talking about this for a long time. It's time. Integrate mental health into care practice. In many ways, we've separated those two things. The needs and the critical impact of mental health, especially during the COVID, was a real good reflection of what was going on below the surface even before COVID arrived. Of course, social determinants of health are important. We're recommending that as hospitals move forward, that instead of using virtual as something you would do only if you can, but really relook at healthcare delivery and consider virtual first. What can we do with virtual up front before we bring the patient in to make both the care convenient for the patient, but also put less stress on the care providers? And we'll go on and on and on through this. But again, we go through these recommendations, and these directly are linked back to the problems. So that's a lot, everybody. I encourage you to go to the journal or go to TTAC and read the plan. I'd love to have your feedback. I recommend that you go to the same sources and look at the policies, the policy issues, the reimbursement issues, and the recommendations. And then when this last section is published, which will be next month, that you go to this as a source. And again, it will be published again with any peer review magazine, where there's no guarantee of it being published in the journal. It has to meet the peer review criteria, but it will be submitted for publication in the next about 6 weeks. It will be published on TTAC regardless. So are there any questions?
Sorry about that. I was wondering what you were doing. We don't have any questions, so please submit your questions into the chat box, and Mark would be happy to answer those for you.
I won't be surprised if no one has any questions on the pandemic.
We have a couple comments. Great presentation and informative. Thorough review.
You can even call if you just disagree with us. So that's accepted too.
Not a single question.
Darn. Well, where's the link to TTAC?
I'll get that for you.
Okay. Patricia will distribute that, but basically go to the National Telemedicine Technology Assessment Resource Center, that it will take you directly to their website. And within their website, look into toolkits. And you should be able to find it quite quickly. If you have any trouble finding that, I popped up 3 names: Patricia, Doris, who most of you know, Jordan, who most of you know, and myself. We'll help you find it no matter what.
Well, since we don't have any questions, thank you, Mark. Aria, do you want to take over?
Sure, yes. Thank you again, Mark, for your presentation. I'm just going to bring the closing slides we have here. One sec. There we go. Just a reminder for our next webinar, it will happen on March 17th. It's going to be hosted by the Great Plains Telehealth Resource and Assistance Center. It's going to focus on the digital health in homes and communities, emerging opportunities for patient engagement. Registration information is available on the NCTRC website. And lastly, there will be a short survey that will pop up at the end of this webinar. Please take a few minutes to complete that survey. Your feedback is really important to us. Thank you again to the Telehealth Technology Assessment Resource Center for hosting today's webinar, and for Mark Vanderwerf for his great presentation. Have a great day, everyone.